Hello, everyone. Welcome to the GSA Momentum Discussion webinar, Geriatric Oral Health and COVID-19 Old Problems, New Challenges, Part 2, Case Studies. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live presentations. We will be accepting questions through the questions feature accessible on the GoToWebinar panel. Also located there are downloadable handouts, a copy of the presentation slides. So without further delay, I'll hand the microphone to Dr. Stephen Schuman at the University of Minnesota School of Dentistry.
Thanks, Judy, and welcome to everyone to this GSA Momentum discussion where we explore topics now experiencing interest and energy in the field of gerontology. As Judy mentioned, our handouts and copies of slides are available from your screen. This is the second of our series of webinars exploring COVID-19 and geriatric oral health, and we have a 60-minute program today of presentations followed by question and discussion. Our sincere thanks once again to GlaxoSmithKline Consumer Healthcare for sponsoring our session today. Well, it actually was snowing here in Minnesota this morning in the Twin Cities. That must mean I'm Steve Schuman from the University of Minnesota School of Dentistry, where I direct our geriatrics program, and I also serve as chair of GSA's Oral Health Work Group. It's a privilege to be moderating this discussion of real-world experiences in geriatric oral health care since the onset of the COVID-19 pandemic. And as at our first webinar last week, it's an honor to introduce a distinguished panel of speakers to you. Dr. Mike Helgeson is co-founder and CEO of Apple Tree Dental, a nationally recognized innovator in promoting oral healthcare access to a broad range of underserved populations, including older adults in long-term care. Dr. Helgeson has held leadership roles in many professional organizations, including the Special Care Dentistry Association and the American Dental Association, and also has won many awards for his and Apple Tree's accomplishments. Dr. Jeff Dodge has practiced general dentistry for over 30 years in Rhode Island and is currently lead dentist with Mobile Dentistry CareLink. He is a past president of the Rhode Island Dental Association and has served on many committees and councils at both the state and national level, along with his involvement in numerous community service activities. Dr. Sam Zwetschgenbaum is Rhode Island's State Dental Director and State Medicaid Dental Director. He has advanced training in both prosthodontics and geriatric dentistry and has taught at both the University of Michigan and Rutgers, as well as practiced in both federally qualified health centers and nursing homes before his current leadership positions in Rhode Island's Department of Health and Office of Health and Human Services. Next slide. Here's our agenda for today. Dr. Helgeson will first discuss experiences with teledentistry, and then Drs. Dodge and Zwetschgenbaum will discuss their experiences in dental practice and long-term care in Rhode Island. Our Q&A and discussion will then follow. Next slide, please. Well, here's a sign of the times. I think this is the pandemic Playhouse from the New Yorker, which captures how a lot of us may have felt in the past several months. A couple on Roz Chast's famous cartoon couch fantasize whether people on TV might actually be going somewhere, like the subway, or maybe a restaurant, or we might add, maybe even for some dental care. We know that significant barriers already existed in geriatric oral health care access and then seemed to get even worse during the pandemic due to concerns about COVID-19 risks in this population and potential risks of dental treatment. So our GSA Oral Health Work Group dug into this issue, which led to this webinar series and some other projects we now have underway. Last week at our first webinar, our expert panel gave us a great overview of key COVID-19 issues related to geriatric oral health, and you can access the recording of that session via the GSA website if you couldn't attend or would just like to review it. Today, we want to turn our attention to how these issues are being addressed on the ground so that we can try to better understand what might work or not work to promote better geriatric oral health under these challenging circumstances. So to lead us off in our COVID-19 case studies today, I'm pleased to turn things over to Dr. Mike Helgeson from Appletree Dental.
Great, thank you so much, Steve. It's a great honor to be part of this presentation, and I'll be focused on successes and challenges with teledentistry and providing some insights from the COVID-19 pandemic. Next slide. And again, I'm Mike, the CEO at Appletree Dental, and as Steve mentioned, I'm a member of the American Dental Association's National Elder Care Advisory Committee and a past president of the Special Care Dentistry Association. Like to speak just a little bit about Appletree Dental. Next slide. We operate 8 centers for dental health in Minnesota, and we deliver mobile care at about 145 community sites serving people across the age spectrum, but including seniors and elders in long-term care. And most recently, even during the pandemic, we opened our 8th center, which is in Fairmont, Minnesota. It's actually an Appletree center that's within the Mayo Clinic down there. Next slide, please. So one of the unique things about Appletree is each day we send out trucks that haul mobile dental equipment and drop it off at these various partnering community sites. Our teams that provide care there are connected with a cloud-based electronic health record. So they're able to do telehealth consultations in any direction live between various locations. And they can do that either live or through updated store and forward or asynchronous teledentistry links. Next slide. So at Appletree, we've created mobile dental offices that are functionally equivalent to traditional dental offices. You can see the little wheel on the dental chair circled there. And then I wanted to point out this new device. This is an external dental suction that in the mode that it's in this photograph is removing air, and it has ultraviolet light and filtration systems inside of it that kill COVID and other pathogens that are in the air. So it works as kind of a room air cleaner when it's in this mode, but the little boom can be put in front of the patient's mouth and removes aerosols when we're doing fillings or cleanings or other procedures that produce aerosols. So this is a new thing in the COVID epidemic. Next slide, please. So I'd like to talk a little bit about the history of teledentistry at Appletree. Next slide. We're one of the first organizations in the country to use teledentistry for primary oral health services, and that started 18 years ago with a clinical dental and education innovations grant that focused on school-based teledentistry. And the first projects were live teledentistry projects where we had a hygienist in a school and a dentist in an office. And we had a live video connection and live transmission of high resolution intraoral images and digital radiographs. So that's kind of how we got started. We moved mostly to asynchronous or store and forward. It became clear that it was much more practical and time efficient to gather all the information at the remote site and then have the dentist do the evaluation of the information and formulate the treatment plan and all of that in an asynchronous mode. Then over the years, we've done a variety of different projects. The last few have been medical dental telehealth projects. The Little Falls project is where we've co-located a dental clinic in medical primary care in a rural hospital setting. North Metro Pediatrics, you'll see toward the bottom there, is integrating oral health with a pediatric medical practice. And there we have an advanced dental therapist as the frontline clinician. And then the Medelia project is also a hospital-based project where we have a dental clinic in a hospital setting. And then the most current thing is what I'm calling pandemic teledentistry. Unlike all of the earlier teledentistry projects where we had either a hygienist, a dental therapist, or a dentist at the remote site gathering data, and then transmitting information to a teledentist at the host site, in pandemic teledentistry, we're introducing direct to patient or direct to patient through their caregiver teledentistry. So that's kind of the newest wrinkle. Over on the right side is just a little snapshot of a teledentistry white paper that Paul Glassman has written. And for people that are interested in really digging into teledentistry in more depth, I would route them to Dr. Paul Glassman and the teledentistry white paper there. Next slide. So now I'd like to just hone in on what are some things that have happened and what are some insights and challenges that we've been dealing with the COVID-19 pandemic. Next slide. So one of the things we did at Appletree is we created a COVID-19 command team back in March when the COVID pandemic began to really impact the practice of dentistry. And some of the key people that were on that team are pictured there. And then we set up a number of sub-teams that focused on different issues, teams focusing on state and federal funding opportunities to help sustain the program, a group focused on the evolving and continuously changing clinical guidelines from the CDC and the Board of Dentistry, and also developing training for our staff, which was evolving throughout the COVID process. An early issue was PPE procurement, both getting our hands on PPE and also preventing early steps on the government's part to try to restrict dental providers from even having PPE and even requests for dental providers to turn in PPE. So we're very active in that whole process. Another ongoing issue is COVID-19 testing, and Dr. Schumann mentioned that in order for him to do clinical work at the nursing facility he works at, there has to be weekly COVID-19 testing, and that's a requirement that varies by location around the state, but it's a major issue for getting our staff back into long-term care facilities. So we have a whole committee working on that and developing our own ability to administer our own COVID-19 tests. We have a team working on community communications, finding out what's going on in our long-term care sites, our schools, our other sites, and linking up with them and making contingency plans to be able to maintain oral health under all of the various restrictions and limitations of the pandemic. Then we had a teledentistry team, and their job number one was to develop direct-to-patient teledentistry, and I'll talk about that more on some subsequent slides. We had a heating, ventilation, and air conditioning team that looked at air quality and steps that we could take to make the operating environments that we work in safer in terms of preventing aerosol transmissions of the disease. And then, of course, fundraising to keep our lights on. Next slide. So we dealt with a number of policy issues, and we have a group called Dental Access Partners that includes one of our tertiary care hospitals. And we linked up with a group led by Sheila Riggs at the School of Dentistry that meets on a weekly basis throughout the COVID crisis and shares notes and works on projects together and so on. So it's been a great benefit to have all that teamwork. One of our early successes was getting PPE for dental providers squared away and getting allocations of PPE from the Board of Dentistry. Another was getting our Medicaid program to cover teledentistry visits. There were federal waivers to cover medical telehealth visits, and we were able to secure Medicaid payment for dental teledentistry visits. So that was an important accomplishment. And then we worked with the American Dental Association through the National Elder Care Committee to clarify that dental providers are in fact health providers and not visitors in long-term care. Early on, there was some guidance that was, I think, a little confused about that. Next slide. So the impacts were on our clinics, where we had to limit our services to emergency only services and develop protocols to be able to provide emergency services throughout the pandemic. We had sometimes one patient a day from nursing home facilities from around the state coming to our clinics for emergency dental services. And then we obviously nursing facilities were among the very first to kind of close their doors to visitors and to dental providers in particular. So we've been working with all these facilities throughout the pandemic. Next slide. So developing this direct to patient teledentistry was a focus area. And we used our existing electronic health record software and paired that with Microsoft Teams software, which has both web-based and free applications that run on all types of phones and tablets, and they are HIPAA compliant. So we developed training for our staff to set up teledentistry direct to patient visits. And next slide. Next slide, please. There we go. We developed instructions for patients about how to participate in such a visit. They're able to run the software from their phone, either just using their browser or downloading the free Teams app. Next slide. And then training for them on how to take good pictures of different parts of their mouth so that the provider can see the issues that they're talking about. Next slide, please. So we set up a committee about relaunching oral health services and long-term care. In March and April into May, dental providers were barred from entering long-term care facilities. And Dr. Ashley Johnson led that team. We did a survey of the facilities we serve to gauge their readiness to resume services. We also coordinated with facilities to provide emergency services for their residents and to work on relaunch activities. So next slide. So this is a survey that we did. We offered 3 ways of resuming services. One, through teledentistry virtual visits, where nursing staff members would work with individual patients and help them participate in a sort of indirect to patient teledentistry through the nursing staff. The second one is having one clinical staff member enter the facility, a dental hygienist, so they could come in. This is more like the traditional teledentistry that we've been doing for a long period of time. And then the third one was readiness to have our full dental team resume services. Next slide, please. So this is kind of a zoom in on their responses. We had 66 facilities that responded. 26 were ready for teledentistry visits, 35 for on-site dental screenings with the hygienist, so allowing the hygienist to come back in. 39 were ready to have the full dental team come back, and this was in the July timeframe. And 11 were not ready to resume services at any level at that time. Next slide, please. So these were some of the survey questions that we asked. You know, if you're not currently prepared, why, and what would help you become ready. The second one is, if you are ready, what are some of the screening procedures that would be required when our staff show up to provide services? And over on the right of this slide are just a few of the answers, responses of the kinds of screening procedures. And I think the biggest issue is that many of the facilities are requiring weekly COVID-19 tests for staff to be able to come on site. Next slide, please. So some of the challenges that we've been dealing with are just that oral health services have been on a back burner. These are not the top priority, you know, during the pandemic. And so just getting time and energy to meet and to talk about oral health services have been an issue. And then the nursing facilities themselves have been experiencing continuously changing guidelines, and they're complex, and it's been taking them a while to figure out, just as with our dental clinics, you know, how to operate under these new and changing guidelines. And then as more and more staff are either testing positive or are living with somebody who's testing positive, there are staffing shortages on everybody's healthcare teams, and everybody's has to kind of punt as people need to be in isolation for periods of time. And then, as I mentioned, the COVID-19 testing requirements for caregivers, we've developed a capability to do our own COVID-19 testing, but we're having all sorts of issues trying to get paid to do those tests. So COVID-19 testing continues to be an ongoing problem. And then finally, providing training during the pandemic is really difficult with all of the different logistics involved and so on. So those are some of the challenges that we've been facing. So that's a quick overview of what we've been doing, and I look forward to the Q&A period. Thank you so much.
Terrific, Mike. Thanks so much. Great discussion. I think that final slide about the challenges is, you just said it all right there as far as what's happening in facilities. I want to now turn to some practical perspectives from our participants, our speakers from Rhode Island. So I'm going to invite Dr. Jeff Dodge to take the mic. Do we have Jeff there?
Judy, I'm not hearing Jeff.
I'm not hearing Jeff either.
Our apologies. Please stand by. I'm going to work to try and restore the audio. How about now?
No.
Do you think we should?
Hello.
There we go.
Jeff, are you
Can you hear
there?
me now?
Yes, we can hear
Okay.
you now.
Sorry about all that. Everything was green here. Thank you very much for the opportunity. I appreciate everyone's time today. I think basically what I'm seeing in the private practice world, and to a certain degree in the community care settings, is what's demonstrated in the slide here. There's basically a tremendous amount of stress associated with this whole pandemic. There's an isolation that people have encountered. They're not able to see the families to the level they would like to. There's a certain fear that's bothering. They don't want to catch the virus. They don't want to spread the virus. A lot of our older patients, which I have quite a number of in the practice, they're getting a lot of feedback from their children, excuse me, to not be going out into the community, to be careful going to the store, and they're doing a lot of shopping for them. Many of them are now single adults. They've lost a spouse, or worst case scenario, they have a spouse who's in some type of congregate care setting, which they might have gone 5, 6, 7, 8, 10, 12 weeks, not even be able to visit that spouse. So much of that gets manifested in tooth grinding and clenching, and we can see the results right here where we have an anterior bridge that the tooth is broken off right inside the crown, halfway down to the gum, below the gum line, right at the bone level. And as most of us clinicians know, those are nearly impossible to restore. So these are 3 front teeth, and this patient here happened to be an auctioneer. So we have to do a lot of hustling to get him put back together on the short term. Even though we are wearing masks, that does help our process a little bit. It's still a real problematic situation. And we all try our best to keep our best foot forward and move forward through our daily life, but it does impact on us as a low level stress that's throughout everything. The other thing that we're dealing with is a delay of care. We in Rhode Island were asked to close down and shut down basically for anywhere from 8 to 11 weeks, depending on the practitioner's comfort level. We did go in and see emergencies, but as takes time always, the science doesn't really stay in pace. It takes a while for that science to catch up. So we basically had situations where we didn't know what to do. We had different styles of masks. We had different ways to try to clean the air in the room. We're trying not to use hand pieces and not trying to generate a lot of aerosols into the air. Aerosols have been a real question for us moving forward. So whenever there's a delay of care, of course, we see infections that get started and continue. We see the broken teeth. We see issues like, again, on the slide here, situations that are hard to remedy very quickly. And we've lost a lot of this time in the office, ramping back up within my own office and most other practitioners in the state of Rhode Island. We basically have a shrunken office, as I call it. We're working with a small to non-existent waiting room. In my case, I'm asking patients pretty much to stay in their car, give us a call when they arrive for their appointment, and we bring them in based on having finished with the last patients and they've left, so we don't have people bumping into each other at the front desk. We have some plexiglass barriers we've installed. We're sanitizing their hands, checking temperatures, checking the pulse ox, asking a series of questions. So our appointments have actually expanded, and we're not able to see as many patients in the course of the day. So catching up has been a problem. The other part we run into is just the unfinished business. February and March, early part of March, we were getting prepared with removable partials, crowns. Since that shut down and subsequent attempts to catch up, we've had teeth have shifted, so partials no longer fit. We need new impressions. People have broken or lost temporary crowns. Teeth have drifted, crowns don't fit. Again, re-prepare, new impressions. And other teeth are fracturing. The occlusal relationship, the bite is very important with most anything we do in dentistry. And if we're unable to replace those teeth on the lower right and the lower left with that removable partial, now the upper front teeth start having problems. And we have breakage there. So it's been a challenge for us to try to coordinate everything. And I think in my case, one thing that's been helpful is we have a lot of good long-term patients that we're able to communicate with. So I guess it's a little different type of teledentistry that we've been doing, just trying to keep track of where they stand and what we can do in the short term and in the long term to prepare them to deal with things the best that we can. The other issue that we run into is issues with the gum tissue. We see a lot of inflammation. Patients have missed their scheduled cleanings. Some people have not been seen for up to a year, the way everything works out. And if you have any type of impairment at all, be it a physical impairment with arthritis or any type of residual stroke effects, or even visual impairments, it's hard to floss the teeth. It's hard to get in there. So we're noticing a lot of issues with the gum tissue, which again require additional appointments. Harder to get these patients in. So I think that's really the biggest private practice side of it, is trying to manage the stress level that everyone has and coordinate that with our own staff, who has to go home to family and have loved ones that they take care of at home, many of them younger and older. Now that school has started and many of them have children and grandchildren in school, that's added yet one more wrinkle. So I think we persevere and continue to move forward to the best of our ability. I think that as far as the long-term care facilities are concerned, we're seeing a very similar situation. In our case in Rhode Island, the CareLink group, which is mobile dentistry and also mobile physical therapy, podiatry, audiology, we're finding that our partner long-term care facilities and assisted living facilities, about 20 to 25% of them really don't want us back there. They're not allowing any vendors in. Many of the facilities have had outbreaks of the virus within. They're very particular about who does come in. As Mike alluded to earlier, we're talking about weekly and bi-weekly COVID testing before we can enter these facilities. We have to be available, have our testing results available. They may be asked for. You know, in dentistry, we've always been on the forefront with gloves and gowns, and now we've added additional levels of masking, face shields, specialized equipment within the operatory to help clean the air. So it has created a lot of problems for us there because those are very difficult appointments. If you could switch to the next slide, please, Judy. As you notice here, we do have portable equipment. I kind of took this picture here because many of the older clinicians in the audience will remember the days of mobile dentistry, as we used to call it, about 25 or 28 years ago, where you went to a nursing home, they ushered you into the beauty salon, showed you a beauty chair, handed you a flashlight, and had 20 patients lined up outside the door. So at least we now are in a situation of having, you know, some pretty much state of the art from my standpoint of mobile equipment that we can actually move a couple of us relatively easily. This chair folds up, zips into a nice little bag. The chair is adjustable both in height. The back of the chair goes up and down. Two of us can effectively move these chairs and all our equipment in and out of the nursing home on a couple of carts in a very short period of time. The chairs support, you know, just slightly over 300 pounds. So we're able to do things in these chairs that we could not do in the sit-up beauty salon chairs. We're doing simple extractions, straightforward extractions. We're able to do a lot of restorative work. And again, as I alluded to earlier, in the nursing home, as in the private office, a number of broken fillings, broken teeth, a lot of sharp edges that are digging into people's tongues and the inside of the cheeks. Sometimes difficult for them to really communicate that to the caregivers. So with this equipment, we can go in very effectively, take care of those problems. It's really not our private office, but it's pretty close. That little gray box in the back with the little hoses you can see is a portable dental unit. That weighs just under 40 pounds. That's just like pulling a rolling suitcase. Compared to one of the ones which we just had to put out to pasture, if you will, from the facility here at CareLink, which the same thing weighed over 65 pounds. So a lot of progress has been made, and it's enabling us to really do a lot more work in the congregate care setting, which is a huge plus because we can take care of minor problems very quickly. The patients do not have to leave the facility, which means they don't have to quarantine when they return, and it can be done in a timely manner. So I think all of those things add up to just the ability for us to take care of those patients at a much easier level and keeps them out of the private offices, which again are really kind of strapped for time as well. So those are just kind of a few of the things that I've been seeing and how they relate to private practice and the long-term care facilities. So I look forward to helping people with any questions or anything later on. So thank you very much.
Thanks, Jeff Dodge, for that, sharing those clinical experiences and perspectives with us. We now are going to hear a little bit more about what's happening in Rhode Island's long-term care facilities. So we will turn things over to Dr. Sam Zwetschgenbaum.
Good afternoon, everybody. It's a pleasure to be with this group. I wanted to take a few minutes just to share from a person working on the State Department of Health side about what my experience has been and some of the things I've seen. Again, none of us ever expected any of this in our wildest dreams, but it's all, it came, and we've hopefully all been learning. Just as prior to COVID, much of my work is either with the Medicaid program providing dental guidance or through the Department of Health and some of our grants from CDC and HRSA in terms of preventive efforts, surveillance, and workforce development. A lot of my time is also relationships with the dental community, and that was very important as we proceeded through this challenging time. What was interesting working for the Department of Health is at the very early stages, they needed people just to help with some tasks. And I think when it first happens, hey, anybody want to volunteer and make some calls? So I remember late February, early March, calling people just to tell them that their test was negative. I think that was my assignment, calling people to tell them that their test was negative. And they really appreciated hearing that news. Unfortunately, I will say that we learned later on that many of the people we told their tests were negative because of some of the inaccuracies may not have been. But again, it was all a development. And then one day, like many working at the Department of Health, whether you were working in environmental health or oral health, you received an email saying you were being deployed, and kind of like the military. And I was deployed full-time to the nursing home team, which basically meant taking phone triage notes that came in from calls from nursing homes or nursing home staff or anything related to nursing homes and COVID. And I would get a stack of papers. It's kind of like being in the military. You'd go get your stack of papers and make your calls. And I was calling very often CNAs who were symptomatic, and I'd have to talk with them about arranging their test. And for many of them, we started to realize that many of our CNAs are from lower socioeconomic status, and our testing sites, you had to have good car access. Many of them didn't have cars, and many of them lived in homes. We would say, okay, you need to use one bathroom, and your other family members have to use another bathroom. Well, we only have one bathroom in the house. So that was very educational. And also guiding the nursing homes when they had residents who were positive. How did they manage that? How did they manage the infection control? So that was it was very educational from my side. I had also seen, like many dentists in Rhode Island, many dentists wanted to volunteer. We wanted to be available to help with any efforts, whether it was some of the makeshift hospitals, whether it's in the future with vaccination. So I volunteered through what we have in Rhode Island called RI Responds. You basically just go to their website and register. You get emails about volunteering opportunities. Well, lo and behold, one of the emails that came through was they needed help for people to be sort of substitute CNAs. And while I don't have training as a CNA, since I did have experience working as a dentist in nursing homes in the past, I thought this would be a great opportunity. And I remember one day I went and I was essentially helping to serve meals. As you know, many of the nursing homes were very, very low on staff. And one of the things I always thought about was what's happening with daily mouth care. If these CNAs are being taken to do many, many tasks with fewer staff, it was going to be difficult. So I got involved with that. One other time I went, I came in the morning and I said, okay, what do you need me to do? And they said, we would like you to spend the day sitting with this individual who is actively dying. And for me, that was such, first of all, I gained such wonderful respect for CNAs because the whole commitment that they had to this individual, not wanting him to die alone. They knew that the family could not come in, but the family wouldn't want to know that their father died alone. So I sat with this gentleman. And then one time, one of the CNAs came in, a young male, and I don't think he even knew I was a dentist, but he came in and he provided mouth care. And I was just so impressed that he was doing this, that as part of the end of life care, he realized that him being clean and being comfortable was really critical. So again, this was an experience I'll never forget, and I learned a lot, and I gained great knowledge about CNAs. The other big challenging aspect through all this is maintaining communication to the dental community. There's a lot that's, especially in the beginning, that was very much unknown, and putting together communications to tell or to essentially ask the dental community to shift to emergency only care from to delay routine and elective care. It was challenging, but again, based on some of the information we knew, we try to keep those communications regularly up to date. I can tell you we have a communications staff that has, they're working day in and day out and on their communications in many areas. So to get them to do changes to dental guidance, it often takes many weeks, but we just did an update the other day based on some of our newer knowledge now that we know that dentistry is going along very safely. Another part of my work is to respond to questions, and when there are positive cases associated with dental offices, what to do. And those are strictly employees or staff working in dental offices who've become positive due to activities outside of the office. We provide guidance to dental offices of what to do. As far as transmission through dental offices, we have not seen outbreaks, which I think is a testament to the significant efforts that offices are doing to mitigate spread. As far as return to oral health, I'm no longer deployed to the nursing home service. I'm back in the oral health program, and a lot of my work is reaching out to the dental community, including some of the work with Dr. Dodge and CareLink. So that's been really positive. So I'll shift to the next slide, please. In preparation for this presentation, I wanted to just get some information on how things were going with nursing homes. And one of the things we had been talking about with CareLink and Dr. Dodge was, where is their site of care? Where is the best place to perform? And what I had heard from his team was, we want a place that's easy to clean. Ideally, we'd like a place that has some ventilation. So I wanted to include that in the survey. So I'll go through this survey and then we'll go through some of the answers. Hope it makes an interesting discussion. So first, I wanted to get a sense of their willingness and ability of nursing homes to adapt, some of their attitudes. What's been the impact of COVID-19 on dental and oral health? And one of my goals is I wanted a survey that was very short, because they get a ton of surveys from the Department of Health, and I didn't want to be just one more. So I got 20 respondents. Actually, now I have 32 respondents, mostly from nursing homes, mostly from administrators. Next slide, please. And I basically wanted to get, first I wanted to get a sense of their population's use of dental care before the pandemic. So I asked them, can you give me a sense of what proportion of your patients never go to the dentist, what percentage go out to the dentist in the community, what percentage receive care from a dentist or hygienist who comes to their facility. Next slide. I also asked, which of the following causes you the greatest concern at this time? Sending residents out to the dentist, bringing dental providers into the facility, both of the above, none of the above. Next slide. This was based on a thought, if we could use this as an opportunity to improve the location of care of dental providers, would there be opportunity to put a dental team in a room that had good ventilation, had good sinks? So I asked, if you are able to provide a separate room in your facility for dental care for a visiting dentist, which of the following does it have? Does it have a sink? Does it have ventilation with at least 4 air exchanges per hour? And I know, Mike, you talked a little bit about ventilation and HVAC. We can talk about that more. Does it have a window? Is it open and uncluttered? And then a couple other options. Next slide. And I wanted to know, and again, this was kind of based on what I saw when I was at that one nursing home in Woonsocket, where the CNA did do a wonderful job. I wanted to know, did staffing impact their ability to provide mouth care? And then next slide. And then has COVID impacted your ability to train your staff in mouth care? And we all know how quickly staffing changes and how important frequent education is. So let me show you quickly some of the results. Next slide, please. Oh, and then we had opportunity for open responses. Okay, sorry. Next slide. So again, 60%, as far as dental care pre-pandemic, 60% reported that more than half of their residents receive care from a dentist or hygienist who comes to the facility, and 2/3 reported less than half of residents go out to a dentist in the community. And this actually, now that I have more data, we see that definitely there's a preponderance of patients who receive care in facility as compared to those who get sent out. So that shows the importance of the service that both Dr. Helgeson and Dr. Dodge provide. Next slide. What causes you the greatest concern at this time? And again, the newer data is pretty similar. So about 30% said sending residents out, 10% bringing dental providers in, 50% said both, and 10% said neither. So I think there's still a lot of opportunity for education about the safety. And I think as we move forward, educating about the safety of bringing dental providers is important. Okay, next slide. And as far as if you are able to provide a separate room, which of the following does it have? Most said they're able to provide a room with a sink. I think this one about ventilation with at least 4 air exchanges, I think that may either be that they aren't able to provide that or they don't understand what 4 air exchanges is. So if I do the survey over again, I'll make sure to elaborate. Most are able to provide a window, an open, uncluttered room. So again, I think there's openness to having a room. And part of this was also based here in Rhode Island, the census at nursing homes, as it goes down, it might create opportunities for creating a proper room to provide dental care, perhaps out of a residence room that has a window. Next slide. And did CNA staffing changes affect your staff's ability to perform daily mouth care for residents needing assistance? 75% responded no, there was never any impact on our ability to perform mouth care for all who need it. And 10% said yes, mouth care was impacted by staffing challenges. Next slide. And finally, the most recent training for 60% was in the past 12 months. And actually, I'll say with newer data, as the newer data came in, 50% said their last training was in the past year. 43% said they have not had training in over a year. So I think that's actually probably indicates that COVID has impacted the ability of their staff to get regular mouth care training. Next slide. So again, as far as free comments, several responded routine dental care would be resuming this month. Several responded they are aware of residents who need care at this time, and most all responded continued frustration obtaining care, including extractions for residents with Medicaid. And next slide. And again, I think that's, and we can talk about this in the discussion. I think there are a lot of opportunities to educate facilities about safe settings for dental care. Mouth care does not appear to have taken a backseat based on this survey, but there are significant dental problems. I will say that the survey was completed by administrators, so there is potential bias depending on who performed the survey. So thank you very much.
Great, thank you so much. So we are entering the Q&A portion of the program, and just a friendly reminder, you can type in send questions using the questions feature, and I believe we have Dr. Schumann back online.
Yep, I'm here, and I just wanted to thank Sam for that information from the long-term care provider survey in Rhode Island. First question in is from Mike Helgeson. What has been the replicability and scalability of the projects you mentioned?
I'm not sure if I'm familiar with exactly what that question means. So I wonder if the questioner can clarify what they mean by that.
Okay, we'll put that out there to whoever
Yeah.
wrote the question to see if they can do that. In the meantime, Mike, any thoughts about some of the challenges of teledentistry in the older population in particular? You know, we've got a population with sensory issues and potential cognitive problems, and of course, access to technology and issues, and in a long-term care setting, maybe even the availability of staff to help people do that kind of communication. Any improvements you see on the horizon to help us with this?
Yeah, our main challenge with that has just been training. You know, the facilities have been so busy with all the different changes and other training and other issues that they're dealing with. And we have a set of facilities now where they're allowing our hygienists back in. And the hygienists, of course, are equipped with the high resolution intraoral cameras and digital radiography and things like that. And then they can be there in person and can do some coaching and training in person. But really, as a practical matter, to do a direct to patient teledentistry, it's really indirect in long-term care. So you really need to have a nurse or a CNA, somebody with the patient who can operate the phone or the tablet and can take the images and can deal with the technology. Very few nursing facility residents are able to do that themselves. And as a practical matter, having two people there, one who's dealing with the phone and facilitating the interview and taking the pictures is really critical. And while we're able to provide the kind of information you saw in the slide there, really having some actual training for the person at the facility, so they're comfortable to use their phone or tablet and to facilitate that would help scale that up. So I think in the long run, that's going to be very beneficial. I think one of the things that we've learned both in the long-term care setting and for our patients coming to the clinic is doing direct-to-patient teledentistry as kind of a limited evaluation pre any visit to the clinic makes a ton of sense. Because we can gather additional information and determine whether or not they really do need to come to the clinic, and if they do need to come to the clinic, exactly what it is that we're going to do, so that when they come in and when all this PPE is being used and all this extra time and effort is being generated for their transportation and all of the things involved in that visit, so that when they have that visit, it's a success and you can get the procedure that they need to have done. And so taking that extra time at the front end, and then many of the issues that are there can actually be dealt with over the phone. Sure. And a patient can be stabilized so that they maybe can delay having that trip to the office until the pandemic settles down.
Thanks, Mike. I just want to toss out a question to both you and as well as Jeff and Sam about reimbursement. And you mentioned what was going on here in Minnesota as far as that. I'm wondering about Rhode Island. I mean, that's obviously going to be a big piece of getting dental offices to buy into teledentistry approaches would be the reimbursement. Any thoughts on that from Rhode Island, or further thoughts from you, Mike?
So, okay. So in Rhode Island, when I heard about, when I heard in the medical side and the behavioral health side that telehealth was being pushed, and the governor had an executive order to relax restrictions on telehealth, I made sure to communicate that through the Medicaid program. Initially, I didn't know what codes to use because I was told you can't add any codes. So basically, now I need to reflect on that and perhaps change the codes we use. But we did allow teledentistry, which again, I think has been used by a lot of the health centers to evaluate patients and prepare them beforehand. I don't know if it has had, again, I don't think, as CareLink has used it some, but I don't know how much has been used in private practice. But we did push, and people at Medicaid were pretty good at getting that forward because there was a waiver.
Mm-hmm.
Yeah, I think also from the private practice side, our major carriers here in Rhode Island did include that and have been paying for that right along since soon after. So that's been a plus for us as well.
Okay. I think actually we're at 12:50 or well 12:56 my time, 1:56 Eastern time. So I think we need to start heading toward our close today. I just want to thank our speakers for their thought-provoking presentations and the discussion today, and to all of you out there for joining us. A special thanks to GSA's team behind the scenes. That's Karen Tracy, Michael Posey, and Judy Liu for their tremendous support in managing our webinar series. And as we close, I just wanted to mention that while professional challenges that we're now facing seem tougher than many of us can remember, we also know that out of such challenges often come opportunities and creative solutions. And we heard about some of those today. And so I think we can and should continue to pull together and use our expertise to continue to promote better geriatric oral health however we can, whether through clinical practice or our teaching, excuse me, research or policy. I'd also encourage you all out there to think about joining us here at GSA in our mission, since as the nation's oldest, largest professional organization in the field of aging, and one that's, I think, also very highly regarded and well connected, I think GSA is well positioned to help address the kinds of challenges we're now facing. I'd also like to remind everyone that free recordings of these two webinars in the series will be available on the GSA webinar page on the GSA website. And so I will turn things now back to Judy to wrap us up.
Thank you. We do ask the audience to please join us on November 4 to 7 at the Gerontological Society of America's Reimagined 2020 Annual Scientific Meeting online. The meeting will be hosted on a state-of-the-art platform that will offer an immersive experience, allowing you to focus on essential research and networking. Please know a webinar survey will automatically launch after the webinar. So in an effort for continual improvement, we would like to hear your thoughts. So please provide feedback by clicking the survey link at the end of the webinar. So on this last slide, a big thank you to the panel, our participants, and our webinar sponsor, GlaxoSmithKline Consumer Healthcare. This is the end of the program.